Good morning, doctor. Okay, the first question is, if the hernia is irreducible, should I reduce it?
Okay, it's a good question. Patient knows the right way to reduce his own hernia. And in short cases, mind you that you don't know what is the history of the hernia. It may be reducible for a long period because of fibrosis. So, in short cases, don't ever reduce the hernia yourself if the patient cannot reduce, because it may cause more pain and discomfort to the patient. So, what should you tell to your respective examiner? Since the patient cannot reduce his own hernia, my attempt will cause more pain and discomfort to the patient, and I didn't know this is a long-standing irreducible hernia or not. So, I cannot perform my deep ring occlusion test, and I cannot conclude whether it is a direct or indirect hernia. Okay, can I have a second question?
Good morning, doctor. So if we do the deep occlusion test and we see direct inguinal hernia, is it possible it can be also the spontaneous indirect hernia?
Okay, I think what you mean is whether there is a simultaneous indirect hernia where the deep ring occlusion test already show a direct hernia. It is possible, where you call this type of hernia as a pantaloon hernia. So means in one time patient has direct hernia and indirect hernia. How to prove it? It's difficult to prove by clinical because the swelling is there already once you occlude the deep ring. So the only diagnosis of pantaloon hernia is intraoperative diagnosis. Okay, next question.
Good morning, doctor. What the differential diagnosis of the inguinoscrotal swelling?
Okay, you must remember that differential of a scrotal swelling and differential of inguinoscrotal swelling is different. Testicular tumor, hematocele, spermatocele, and testicular abscess is not a differential of inguinoscrotal swelling because it is only a scrotal swelling. So, what is the differential of the inguinoscrotal swelling? Number one is it is indirect inguinal hernia. Number two, it can be a hydrocele of the cord, where you have the hydrocele only at the cord or the remnant of the processus vaginalis. Okay. Then the third one is whether there is a cord lipoma, where there is a lipoma along the spermatic cord. These are the usual differential diagnosis of the inguinoscrotal swelling. Okay. Any other question?
Doctor, and the last question, what the principle of management of the inguinal hernia?
Okay. As I mentioned to you, hernia is diagnosis by examination and history taking. So, you should mention that first I would like to elicit the history from this patient to look for any risk factor to aggravate the hernia. Because without treating the risk factor, the hernia tend to recur after the repair. So, you should get the history whether this patient have a heavy lifting activities or job, or patient is having underlying chronic obstructive airway disease, or the patient is suffering from benign prostatic hyperplasia. From there, you should continue with your examination, especially to look for the risk factor. Then comes the investigation. You may do some investigation to determine the fitness for surgery. For example, you may do a lung function test or arterial blood gases to look for the condition of the lung. You may need to do transrectal ultrasound to look for the volume of the prostate gland. Or sometimes you may need an ultrasound of the abdomen to look for any evidence of increased intra-abdominal pressure to cause a effect to the hernia. For example, ascitic fluid or intra-abdominal mass. How to manage further? Upon treatment, before you subject the patient for the operation, you should stabilize the underlying factor. For example, optimize the medication for chronic obstructive airway disease or medication for the benign prostatic hyperplasia. If the patient needs surgery, you may consider a transrectal resection of the prostate gland before the hernia repair. Specifically for the hernia repair, there are three types of hernia repair. Either you subject the patient for herniotomy, herniorrhaphy, or hernioplasty. The basic principle behind this operation is, one is to close or transfix the sac, the hernia. Number two is strengthening the posterior wall. Herniotomy means transfixing or closing the sac. It is usually done in the congenitally occurred hernia in small children or in infancy, where they don't have weakness of posterior wall. Herniorrhaphy means herniotomy plus suturing of the posterior wall by using a suture material. Usually is a Prolene suture. Where do you suture on the posterior wall? Usually from the conjoint tendon to the inguinal ligament. Hernioplasty means you put a mesh. Means you do a hernioplasty plus putting a mesh on the posterior wall. So the condition that required herniorrhaphy and hernioplasty varies. Depends on the recurrence rate and the condition of the hernia. Because if the patient presented with strangulated hernia where there is a risk of infection, you try to minimize the foreign body. Thus, the patient cannot undergo hernioplasty and he should go for herniorrhaphy.